Thank you all for joining this IOPPN Twilight lecture series. Thanks to all the staff and students who've joined us tonight. My name's Rebecca Gray. I'm the Chief Executive of Maudsley Charity, which is the charity supporting better mental health through our work with South London, the Maudsley NHS Foundation Trust, the Institute of Psychiatry, Psychology and Neuroscience, and community organisations in South London. I'm absolutely delighted to have been asked to chair this evening's event, and my first role is to introduce Professor Emily Simonoff. Emily is somebody I've worked with the last couple of years in our work to plan for a very exciting new centre for research and clinical care for children and adolescent, for young people, children and young people on the site of the Maudsley Hospital, which we hope will start to take shape in the next couple of years. But for those of you who don't know Emily, she is a Professor of Child and Adolescent Psychiatry at the IOPPN and is Head of Department at the Institute. Her main area of research, as you'll guess from tonight's lecture topic, is autism and ADHD. She is a Senior Investigator for the NIHR, Senior Clinical Advisor to the National Institute for Clinical Excellence, where she's contributed to a number of national guidelines. She chairs the European ADHD group, and she, on top of all of her academic roles, is also the clinical academic lead for child and adolescent mental health services at South London Maudsley NHS Foundation Trust, and runs one of the national clinical services supporting children across the south of England who have complex neurological disorders and challenges. So highly impressive CV, and somebody I personally admire a great deal. So really looking forward to hearing her talk in a second. She will go through some slides and we'll then have a Q&A. You can submit questions to the Q&A via live event Q&A, and please do upvote questions that you think are really important or interesting, because it's unlikely we'll be able to get to all of the questions this evening, and we will select questions based on the ones that have the most support. So please do enter questions and vote for them. So without taking up any more time, Emily is going to speak to us about the mental health of autistic people, research to improve functional outcomes and quality of life. Over to you, Emily.
Thanks, Rebecca. Thanks for that very kind invitation and introduction. I'm really delighted to be talking tonight. I'm very much hoping, of course, I can't see who's in the audience, but I'm very much hoping that it includes people who know little, if anything at all, about autism and have come along to find out a little bit more. It's an area that I'm passionate about. Autistic people have great talent and an awful lot to contribute to society, but very often are unable to do so because of some of the challenges that they experience. And what I want to tell you about tonight is how we can start to unpick that to help autistic people achieve the kind of outcomes that they want and the quality of life that they want. So, assuming that there are at least some of you who know very little about autism, it's actually quite a recent condition. It was first described by Leo Kanner, who was a child psychiatrist at Johns Hopkins University in 1943, and subsequently in the following year by Hans Asperger, who was a pediatrician at the University of Vienna, both of them writing independently, describing children and adolescents with who were very self-contained, isolated, apparently uninterested in the world around them. And many of you may have read that in the last 4 to 5 years, Hans Asperger has been discredited and exposed as a Nazi collaborator. Very sad story for science and for child mental health, but nevertheless, the legacy of Asperger syndrome as a condition of relatively high functioning, that is people who are verbal and often gifted, has been retained. So from the mid-1940s up through the following couple of decades, that was a time when psychiatry was dominated by psychoanalytic thinking and very little science. And it took work that was largely based here at the Maudsley Hospital by Professor Sir Michael Rutter to define autism and some of the key elements of it. So describing what we now call the triad of impairments, difficulties with social communication, that's using, or social reciprocity, that's being interested in others and responding to their overtures, communication, by which we're sometimes talking about language, but actually we're talking about social use of communication, verbal or nonverbal, and highly restricted and repetitive patterns of behavior and intense and sometimes unusual interests. So until the 1970s, as I said, it was a psychoanalytically driven concept, and refrigerator mothers were described as one of the main causes of autism. But research highlighted that it's a condition that begins very early in childhood, usually in the first 2 years of life. It's evident, even if not necessarily diagnosed. It persists across the lifespan, although very often the manifestations and the challenges for individuals may change over time. Importantly, seminal work here at the Maudsley and King's with the first twin study showed that unlike the idea that it's an environmentally caused disorder, it's highly genetic in its origin, and you know those are factors that persist across the lifespan. So more recently, a number of factors have also become apparent. That graph on the left-hand side may look to you suspiciously like the rate of positive coronavirus tests. I assure you it's not. It's actually prevalence rates of autism as reported in the literature. So when I was a medical student, I was told that autism was an extremely rare disorder, and I might see only 1 or 2 cases in my entire career. Now it's recognized to be a common disorder where that rate, like rates of coronavirus positive test, is plateauing off around 1 to 1.5%, but very much driven by how it's assessed. And the reasons for that increase in prevalence is largely due to better recognition, the use of standardized much-structured instruments rather than clinicians simply saying, I think that child is autistic, has identified that a much wider range of children and young people, and indeed now adults, fulfill the criteria. Also, parents, teachers, and the lay public in general are more aware of autistic symptoms and how they may manifest, and so they're often seeking referral for their child. There has been what we call diagnostic substitution. So children and young people who were previously described as having another condition, whether it's a language impairment or ADHD or intellectual disability, are now being described instead as autistic. And some of that's being driven by, in some countries like the US, increased services if you have a diagnosis of autism. But these prevalence rates represent the research studies, not what we call the administrative or reported clinical prevalence rates. Finally, we can't be absolutely certain that there isn't a true increase in prevalence, but if it were the case, it would be likely due to environmental rather than genetic influences. Other key areas that we've become more aware of in the last couple of decades are first that autism, rather than thinking of it as a categorical condition that is discrete and where autistic people are different from the rest of the population, we think of them now as the extreme end of a continuum of autistic traits, but where there's no natural or obvious single one cutoff point. We're also aware that of the importance of sensory atypicalities, and by that I mean either hypersensitivity or hyposensitivity to noises, touch, and visual stimuli. And this was really put forward by the autistic community themselves, that they said that these are really important features for them and aspects that impact on their quality of life. We're also aware that we still struggle with the identification of autism in women and the most gifted part of the population. So those are some of the areas that we've recognized in the last couple of decades. But what I want to turn to, before I do that, I'm just going to highlight something about what we can do for autistic people in terms of treating core symptoms. So there is emerging positive evidence for early intervention focusing on improving social communication. And there's some evidence that that has long-term benefits. There's also evidence that children and young people benefit from where they can, attending mainstream school with appropriate support and spending time with what I've called here neurotypical non-autistic peers. And finally, the importance of education extending into early adult life. Autistic people tend to gain skills at a later point in time than non-autistic people, but so they're very often 18 to 25-year-olds are developing skills that a non-autistic person might have developed in mid-adolescence. And many people don't know that if you have a diagnosis of autism in the UK, you have a statutory there's a statutory requirement that education until the age of 25 is made available if you want to take it up, and it's really valuable. But what I want to focus on as a major area of challenge for autistic people is their mental health. Until a couple of decades ago, really only probably about 15 years ago, we didn't recognize that autistic people had significant problems in mental health. And as part of a prevalence study to identify the overall rate of autism, we decided to look at how common mental health problems were in autistic people. And what I've circled here on the left-hand side of the slide are the findings from two autism population studies that we've done, one in 12-year-olds called the SNAP cohort and another in 5 to 9-year-olds called the QUEST cohort. And what you can see are that general psychiatric problems occur in anywhere between about 65 and 80% of the cohort. And those compare using the same instruments to 10 to 20% of people in the general population at the same age. So that autistic people are about 6 to 8 times more likely to have a mental health problem. Now, that's a huge increase in risk. Any finding that shows a 6 to 8-fold increase is a risk factor that is a public health emergency. And I'm going to argue that managing mental health problems in autistic people should be considered a public health priority. On the right-hand side of your slide, you can see again for those two cohorts, the three main kinds of mental health problems we see in children and young people. So ADHD, behavioral problems, which are typically problems of oppositionality and refusal to engage in activities that are expected of you. And importantly, finally, emotional problems, which in children are largely anxiety, but as they get older also include depression. So the other thing that's important about mental health problems in autistic people is that when you have one, you have more than one. If you look first at the right-hand side of your graph, what you can see are that the overwhelming majority of autistic children in our studies, those are the green and purple bars, had 2 or more mental health problems in these categories. So ADHD and oppositional behavior, or ADHD and emotional behavior problems. And the Venn diagrams on the left-hand side show the actual overlap. What I want to depict with that is, for example, very often if a child with autism comes to clinic, the clinician may say, you've got ADHD, I know how to treat that. But if you look at those individuals, they're also quite likely to have problems with oppositional behavior and emotional difficulties. And it means that a comprehensive approach to assessment and intervention is absolutely essential if we want to make a difference for autistic people. Okay, now this is a slide from, again, the SNAP cohort I was telling you about, whom we followed from age 12 when we initially described those mental health problems, up to the age of 23. And again, we're looking at their difficulties in these three main areas of conduct problems, ADHD, and emotional difficulties. And what you can see is the broad line in the middle is the average for the whole sample that we followed up. So we see problems decreasing somewhat over time, although you can see that they're still above the threshold. The majority are still above the threshold for having a likely disorder on these questionnaire ratings. But what I really want to draw your attention to is how all the individual lines, which are those thin lines, are following the same course for that that particular area of symptomatology, so that by age 12, you effectively know where someone's going to be when they're 23, because they're all following the same line. And to me, this means that there's an enormous requirement that actually we do something about these problems by the time these children and young people are age 12, because actually we know exactly where they're going to be. We know who we need to intervene with to change that course. Finally, is this important? Well, yes, it absolutely is. On the left-hand side, you have a graph where we asked our young people when they were age 23 to rate their quality of life, and we've broken them up according to whether they had depression or not. And what you can see is a significant difference in their ratings of quality of life across all four domains according to whether they had depression. So it's having a significant impact on their mental health. And as if that wasn't enough, autistic people were asked by the research charity Autistica to rate their priorities for research. And the first priority that they rated was research into the causes of and treatment for mental health problems. So I hope I've convinced you that it's an important topic. I now want to move on to think about why should autistic people have such high rates of mental health problems? Because unless we understand this, we won't be able to develop effective interventions. And I'm going to take you through three possible sets of alternatives. The first is what I call the phenocopy, or the diagnostic under-inclusiveness idea. And this is that what we're calling mental health problems in autism is really just part and parcel of autism. It's nothing other than that. We've just given it another label. And this is an important argument because it's often what happens when autistic people ask to be referred to clinical services for their mental health problems. They still may get the response, it's all part of their autism and we don't treat autism. The second possible explanation I want to take you through is the idea that autistic people have increased risk factors that either are responsible directly for causing mental health problems or indirectly via, for example, increased environmental exposures or negative life events. And the third area is that autistic people have fewer protective factors that in the context of adversity can protect them against developing mental health problems. So first, and I wanted to say that, I hope you can see that this really encapsulates what we call the biopsychosocial, and I've called it sociocultural model, which is a very old model that goes back to in psychiatry for decades, but I still believe it's the only way in which we can understand mental health problems, we need to understand underpinning biology, individual psychological experiences, and the society and culture in which people find themselves. So I'm going to first quite rapidly, I hope, debunk the idea that this is just part of autism and that these symptoms don't have any meaning. And what this slide depicts is the correlations in measures that we've done over the 12 years that children were seen from 12 to 23. And we've given the same questionnaires. So what you can see on the diagonal in turquoise is the same measure, 11 years apart. And what you see on the off diagonals are the correlations across different measures, so different subscales at those different times. And what we would argue is that if this is all just part of autism, the manifestations will change over time, and therefore the correlations across different subscales should look very similar to those within subscale. But what you actually see is that emotional problems at age 12 are highly correlated with emotional problems at age 23 and not with the other domains that we've measured. And the same applies when we look to conduct problems, hyperactivity, peer relation problems, and prosocial behavior. So there's strong continuity within domains and rather than just a mishmash over time. Now, the next two slides are a little bit technical, and they're really for perhaps the more slightly more research-focused individuals. But this is a study that just took a whole series of different items measuring psychopathology down here at the bottom, and said, do they fit into the way we think about psychopathology or the categorization of psychiatric or mental health problems that we think of for typically developing individuals? And the bits I've highlighted in the red boxes are the concepts that we recognize as part of general mental health problems in typically developing or non-autistic individuals. And effectively what this study showed is, yes, the same structure or same pattern of organization applies when we ask about mental health problems in autistic people. And finally, a quick last example of that. It's important because it's such a common problem in younger autistic individuals. Work that started here at the Institute of Psychiatry by Argyris Stringaris, looking at different types of oppositionality and how they mapped onto different elements of behavior are shown here by the bold blue lines. And what Will Mandy did was to say, does this apply in the same way to autistic individuals? And yes, he found exactly the same structure. There was a little bit of overlap here between these two domains, but largely speaking, recapitulating what we see in typically developing individuals. So, first message, mental health problems have a similar structure in autistic individuals as we see in the general population. Well, I want then to move on to is thinking about why do we have such high rates of additional neurodevelopmental conditions in autistic people. And by additional neurodevelopmental conditions, I'm thinking about ADHD, intellectual disability, tics, which are twitches, and coordination problems. And if we look at this slide here, what we see on the left-hand side is findings from a twin study. And just to take you through it for people who aren't perhaps used to looking at results from twin studies, is we can say we have an individual who is autistic and we're looking at what kind of conditions do they have in their co-twin. And by doing that, we can say how much is that due to shared genetic influences, which are shown here in red, genetic influences which are specific to that individual disorder, or environmental influences. And what I hope is self-evident is that for all the other neurodevelopmental disorders that were examined, shared genetic influences that influence autism and additional neurodevelopmental disorders are explaining roughly 50% of why individuals have co-occurring conditions. Now, sometimes we worry about whether twin studies are generalizable. Twins are different. And the same Swedish group, the Swedes always have wonderful data, and we're always very jealous of them here in the UK. But the same Swedish group were able to use registry data to look at individuals with autism and say, what do we see ADHD in their relatives? And what you have here, going from left to right, is relatives of decreasing levels of what we call relatedness. So they're less strongly genetically related. So what you have here, of course, is does the same individual, does that autistic individual have ADHD? And quite a high proportion do. And almost as many of their identical co-twins do, but we see a drop-off as the degree of genetic relatedness decreases. And that is, again, another way of telling us that genetic influences are extremely important for neurodevelopmental co-occurrence. Now, how do these work? We have two kinds of genetic influences that we think about. One are single genes of major effect that cause an individual to have a disorder or not. These are genes where we think about, for example, conditions like cystic fibrosis or Huntington's disease. But we know we've identified now about 10 or 15 genes that have that effect and cause autism, in many cases with a phenotype that includes ADHD and intellectual disability. And that causes autism in about 10 to 15% of individuals. But most of the genetic risk is due to what we call polygenic effects. And this is where we have multiple genes, all of which add together to increase or decrease our likelihood of having a particular condition. So this is the kind of inheritance, for example, that largely affects whether we have high blood pressure, whether we become overweight, whether we have coronary artery disease. And these are important for autism as well. And this is largely what's explaining the overlap between autism and other neurodevelopmental disorders. Why is this important? Well, it's important because if we take this model down the bottom, if we understood over here on the left-hand side how those genes had their effect and could identify what was the intermediate brain-based substrate, so that we could intervene at that point, we would impact not only on autism, but also on ADHD. So we'd be affecting both conditions. And another way of testing this is to look at treatment for ADHD in autism. And we use treatments that are available for typically developing individuals. Largely speaking, we find about half of the effect. So here in blue, we have typically developing non-autistic individuals and autistic people here in red. And what this shows us is that for the common treatments, methylphenidate or stimulant medication, and atomoxetine or non-stimulant medication, autistic people don't respond as well. We have this interesting outlier of guanfacine, which is a different class of medication. We have to be very careful about this result because it's only one trial that's shown that. But largely speaking, at least one of the reasons why we don't get the same response in autistic people is they have a much higher rate of adverse effects that may limit the dose. So here we see that with stimulant medication, for example, about 10% of typically developing individuals have adverse effects, whereas it's close to 20% of autistic individuals, and that's largely due to their autism, and not their intellectual disability, as we showed in one of our studies. So I'm going to move on to the second area of risk factor that I want to think about with you. And this is that cognitive differences that are commonly present in autism, but not exclusive to autism, may increase risk for mental health problems. Now, what do we mean by, or what are the kinds of areas of cognitive differences that we're looking at? I've divided this into three categories here, what we call social cognition, and we're typically looking at two kinds of cognitive capacities, one of which we call theory of mind, and that's the ability to understand what other people are thinking and what drives their behavior, because of the information that you have about them from observation or prior knowledge. And secondly, emotion recognition, and that's the ability to detect other people's emotions, either from their facial expression or the tone of their voice, without knowing what they're saying or without them telling you what they're feeling. The second area is what we call executive function, and these are the cognitive capacities that are important for everyday planning and organization. They include holding things in our working memory, so for me to remember what's going to come up on my next slide and you holding the telephone number in your memory, flexibility to switch from one task to another, and being able to plan in advance. And the third area that I'm going to touch on less today, but is really important in relation to the sensory atypicalities we talked about, are perception differences in the perceptual processing. And we're talking again across modalities, hearing, vision, touch, where autistic people may have either more acute perceptual processing or diminished perceptual processing. And what we and others have done is looked at how some of these cognitive differences may have an impact on mental health. And the first example I'm going to give you is here, looking at how do cognitive differences affect the relationship between ADHD symptoms up here and autism symptoms. And we looked at this by saying we've got symptoms, or we've got differences in executive function and theory of mind, and these are related to each other. This represents a correlation between the two. But what Steve Lukita, one of our PhD students, showed is that while theory of mind differences relate to autism symptoms, it's executive functioning differences that relate to ADHD. And the relationship in this study between ADHD and autism symptoms could be explained exclusively by this relationship between executive function and theory of mind. In a similar sort of study, Matt Hollick's looked at why do autistic individuals develop anxiety and depression, and he looked at social cognitions down here at the bottom, and executive function, and pulled IQ differences out of that equation because we know that these can be affected by IQ. And what he showed, very interestingly, is that the relationship is executive functioning to anxiety, and anxiety is related to depression, but there's no direct path in adolescence from executive function to depression, nor is there a direct relationship from social cognition to either anxiety or depression. The third example I want to show you is in relation to behavioral problems and the relation again to social cognition. So we know in typically developing individuals, those with high levels of behavioral problems and a lack of empathy often show quite a specific impairment in recognizing fear in faces. These faces over here on the left-hand side are what we call Ekman faces. They're standardized photos depicting different emotions, and I hope you could pick up that the yellow face is the fearful face. So typically developing young people may have a specific impairment recognizing fear, and we showed if they've got lack of empathy, and we showed exactly the same thing in autistic youth who also were demonstrating behavioral problems. Vinnie Carter-Lena then went on to look at how does this relate to theory of mind more generally? If you look at this graph here on the right-hand side, and is it the same process in typically developing and autistic individuals? So what you have here are two lines, first for non-autistic people and here for autistic people, related to the on the y-axis, the amount of behavioral problems they were showing, and down here, the level of theory of mind. So less theory of mind is related to higher behavioral problems. But what I want you to see is that these two regression lines, that's what does the whole sample look like when on average, these two are exactly the same. They have the same, what we call intercept, and they have the same slope. What's different is that there are many more autistic people who are having problems with theory of mind. So it's not that the process is different in autistic people, it's just that their impairments in theory of mind make them more vulnerable. Finally, I wanted to think about anxiety in autistic people in this area. So very often we think of the way in which anxiety manifests in autistic people as being quite different. And when we asked autistic people as part of an app that we were developing to list what they were worried about, you get this word cloud. And so some of these are really exactly what you expect for any anxious person to be worrying about: money, school, work, family. And then there are some that are strikingly perhaps different for autistic people, such as loud noises here. But there's a significant impact of these typical worries. And what we know is that the most common treatment, cognitive behavior therapy, also works for autistic people. What you have here is something called a forest plot that summarizes all the studies that have been done, randomized controlled trials looking at cognitive behavior therapy in autistic people with anxiety. And at the bottom here, this little diamond shows you that it's left of this 0 points, showing that when we look at in a meta-analysis at all the trials put together, there's a significant benefit of CBT for anxiety. And incidentally, these studies are rated by when they occurred in time, and there's a typical finding that the earliest studies are the most promising, and as our methodology becomes more rigorous, the degree of significance often decreases, which is why it's so important that we replicate in science. So what does this tell us? First, it tells us that it's essential that we provide interventions for anxious autistic people because they do work. But also what we know is all those trials adapted the interventions to take account of those cognitive differences that we've just looked at. We currently don't have enough resource in the UK or indeed in any country to offer face-to-face individual intervention for the 40% of autistic people who experience anxiety. And so thanks to Autistica and the Maudsley Charity, we've been developing an app called Molehill Mountain to provide an intervention for the earliest stages of anxiety in autistic people, to help them manage the more simple difficulties. I want to turn to two last concepts here. The first is that autistic people have increased rates of adverse experiences. And this is really important for us all to bear in mind. This first slide, which is a national study, looks at a host of different areas of adversity and compares an autistic sample to typically developing non-autistic individuals otherwise matched. And you can see right across all areas of adversity, autistic people are experiencing higher rates. A particular area that we're interested in or want to focus on, particularly in children and young people, is bullying and victimization. And the graph on the left-hand side here shows you high rates of bullying and victimization no matter where you look. So the first set of graphs looking across different continents. Secondly, looking across children versus adolescents, and finally, whether you ask parents or you ask children themselves. This isn't just a statistic. We know that bullying and victimization does lead to increased mental health problems. We know in autistic individuals that they're more likely to report bullying if they're older, if they have more autistic symptoms, and if they already have emotional difficulties. But having accounted for that, followed up 1 year later, they nevertheless have increased mental health problems after that. So this is an example of a modifiable risk factor that needs to be a public health priority. The final area, and this is perhaps the most speculative, but also potentially, I think, one of the most exciting areas. And this is the idea that perhaps autistic people find it more difficult. Either they have less protective factors or they find it more difficult to use them in everyday life. So let me take you through this slide. This is a study that defined what we call resiliency. And we think of resiliency as the ability to show a positive response, or at least not a negative response in the face of adversity. And what these researchers did is they defined a level of resiliency, and then they looked at how it affected what were the rates of resiliency according to whether children and young people had experienced adverse childhood experiences. And on the left-hand side here, you have first autistic individuals and then non-autistic individuals who hadn't had any adversity. And then here, those who had had 3 or more types of adversity. And 2 things to take away. First, the autistic people have less resiliency no matter whether or not they had adverse childhood experiences. And secondly, particularly for the non-autistic people, having adverse experiences reduces your resiliency somewhat. So if we look over here, what this group then did was look at whether having resiliency moderated the impact of adverse life events or adverse childhood experiences. And what they found is that for the typically developing individuals, the impact of adverse childhood experiences on mental health outcomes was mediated by your level of resiliency, where this path was not present in the autistic children. Now, what we don't know is whether it wasn't present because actually their levels of resiliency were too low to be able to mount that sort of response, or whether they simply don't know how to do that. But what it highlights is that another important new avenue of research will be to identify sources of resiliency and perhaps build training so that autistic people, like typically developing people, can use these in everyday life. So finally, this is not a test to see whether you remember this slide from before, but I'm taking you back to this early slide from our SNAP cohort that we followed from 12 to 23, when I told you that by 12, you could predict with great certainty individuals' pattern of emotional behavioral problems into early adult life. We've looked at this same pattern in our younger cohort, the Quest cohort, and we followed them from age 4 to 13. And what I want you to take away is that there's a very different pattern here. Although the overarching slopes, those big thick lines, are very similar, they're a slight decrease, but not much of one, over those 9 years or so. I want you to see that those individual lines are much more varied. The pattern hasn't been set, and it's suggesting to me that we have a unique opportunity in childhood and the earliest parts of adolescence to impact on those patterns and make a real difference to those trajectories moving from adolescence into adult life and hopefully for the rest of the life course. And this really summarizes a lot of the way that we're thinking in relation to the kind of work that we want to do in the Pears Maudsley Center. So if I summarize the key points I wanted to make in this talk, first of all, I want you to take away that mental health problems are incredibly common in autistic people. They're real, they're not a side effect or misinterpretation of autistic symptoms, and we have evidence that they can be treated. Although we need to find more effective interventions. We know that for co-occurring neurodevelopmental disorders, genetic factors are predominate in our understanding of why they co-occur. But for other conditions, emotional disorders and behavioral conditions, we find that specific differences that are increased in autistic people, such as cognitive differences in thinking style and the impact on behavior, play an important role in who does and doesn't develop a mental health problem. We don't fully understand the role yet of protective factors and resiliency, and this is an important area for future research. And finally, this is just this research that identifies the causes and underpinning mechanisms is going to be essential for us to develop targeted, individualized and personalized interventions that make a difference. As I indicated, and Rebecca said at the beginning, we're building the Pears Maudsley Center in the middle of the Denmark Hill campus, where we're going to be investigating problems like this so that we can have a better understanding of mental health problems and develop more targeted interventions. So on that note, I'd like to finish and open it for questions.
Thanks, Emily. I'm hoping that you can all hear me again now. Thanks, that was absolutely fascinating. We've got a good array of questions that have come in while you've been speaking, so I will go through those. Some of them are quite long. I'll take them one at a time. I think that probably makes sense. So the first question is from Alice, who asked, do comorbidities differ in females with autism? Is the research presented focused on males? And what research is being done to improve the diagnosis of autism in females, and how might it differ from the clinical presentation in males?
So really important questions about autism in women. There's both a philosophical question and a challenge to how we conceptualize diagnosis as to whether we should apply different diagnostic criteria and use different ratings for autism in females. We know that we're much less likely to pick it up because females are often more interested in social relations and they show less behavioral disturbance, so that they don't come to the attention of the teachers and professionals in the same sort of way. When we apply the same diagnostic criteria, we know we see less what we might call aloofness or lack of interest in social relationships, but more difficulties in getting the soft elements, the more subtle aspects of interpersonal social communication are still impaired, and so we need to look more carefully. In terms of comorbidities, we see it's been under-researched in one of our cohorts. I mentioned the Quest cohort. We've purposely oversampled girls so that we can compare girls and boys. And what we see is a pattern of comorbidities that looks very much like what we would see in neurotypical populations. So girls have less ADHD and less tics and Tourette's, so less neurodevelopmental problems, a little bit less behavioral difficulty, but it's still an under-researched area.
Great, thank you. The next question is about borderline personality disorder. So why do you think there's so little awareness of and research into the overlap between ASD and borderline personality disorder?
I think, so this is a really important area, and it's something that I think clinicians are increasingly aware of. You could have said almost the same thing about, for example, psychosis and autism. I think it's often because you've got clinicians who come from different trainings and different backgrounds, and so when perhaps a person presents for the first time in late adolescence or early adult life with behaviors that seem irrational, perhaps, or with high levels of emotional regulation difficulties. Very often that history around early development isn't taken. Maybe parents aren't even there to take that history. But if you start to look at those individuals through the lens of early developmental differences, very often we pick up that there have been difficulties from an early time point. I'm really pleased to say that I think our services for young people with these kind of emotion regulation problems that might be seen as an emerging borderline personality disorder. I think our clinicians are very aware of that potential for early developmental differences that might herald or indicate an autism spectrum disorder.
Thank you. So the next question is, actually, there's another question. Oh, here we are. So do all autistic people experience a lack of empathy? In the autistic community, this can be a matter of controversy. What might underlie this heterogeneity, sorry, getting my words confused, in social cognition in autism?
So I think there are very few categorical things one can say, and the most common truism amongst autistic people and autistic researchers is when you've seen one autistic person, you've seen one autistic person. There's almost no feature that you can say applies to all autistic individuals, and that certainly applies to lack of empathy. Many autistic people have difficulty, for example, identifying people's emotions easily, but once they're made aware of or identify for themselves what someone else is feeling, whether they're feeling sad or upset or happy, they can easily empathize with those emotions. So it's not something that's intrinsic to autism.
Thank you. There's another question which relates also to women with autism. It's a question about masking traits and whether can more effective masking of traits contribute to mental health problems.
There's certainly a lot of research. So maybe it's worth saying what masking is, or masking or camouflaging. This is the idea that particularly autistic people try to fit in. They try to hide their differences if they're in a group with other people and perhaps they don't understand quite what's going on, but they look at other people and they see other people are laughing, so they laugh even though they didn't quite get what people were laughing at. That's called masking or camouflaging. Probably increased in females with autism, although it's a recent concept and it's one we don't know a lot about. There has been an argument that trying to mask may increase, in particular, anxiety, and that makes perfect sense. But I think the research that it's a causal process rather than two things going alongside. So you might be masking because you're feeling anxious in a social situation and you don't know what to do. And I don't think we've sorted out that causal pathway yet.
The next question is quite a long one. I'll try not to trip over my words. So it's from Owen. Although it's admirable to develop mental health services for children or young people who are autistic, what about autistic adults? Autism is often viewed as a child-only disorder, but it's not the case and persists throughout lifetime. Therefore, mental health related to or independent of autism will persist too, even if people grow to manage or mask their behaviour, which might give a false impression of improved well-being. Being autistic can be a traumatic experience in a world that's not autism friendly. Arguably, the gap in services lies more so in adults and not children, and it's the transition between these services where available support ends. Well, I know a common question when we talk about children's services and adult services.
Yes, well, I agree 100%. And, you know, for me as a clinician who looks after children and young people, when they turn 18 and we have to hand them on to adult services, you know, it's very distressing because you know that they're going to get very little. And sometimes, particularly at a point in their lives when they can make even better use of services themselves. Very often it's been parents who've been driving services and sometimes bringing their children kicking and screaming, and sometimes literally kicking and screaming as well to see us because they want the best for them. Whereas often by the time young people become adults, they're more aware of what they can do for themselves and they're looking for those services and they're not there. And I completely agree, and please write to your MP and also to the All Parliamentary Group on Autism, because this is an area that they're very concerned about, and NHS England.
Good rallying call there, Emily. Here's an interesting question. Do you find that people, it might have to be the last one, or maybe we can squeeze one more in. Do you find that people now find a diagnosis of autism more socially acceptable than a diagnosis of conduct disorder, or that parents are treated differently if their child has one or the other diagnosis?
So all of our mental health diagnoses have a huge cultural and contextual overlay. And I think it depends very much which bit of culture and context you come from, which diagnostic labels are most acceptable. There's still some aspects of society, including our own local population here in South London, who find an autism diagnosis very distressing. It brings shame on the family, whereas others find it a relief because they think, well, this means it's not something I've caused by my parenting. Ideas about conduct disorder, I think, are equally mixed. So I think it would probably not be right to generalize here, but rather that how important it is to understand what a particular diagnostic entity or label means for any child, young person, adult, and their family, and to work with that on an individual basis.
Thanks so much, Emily. I'm afraid we've come to the end of our time. So although there's some really interesting questions, we don't have time for all of them. Emily has shared her email address there and has said she's very happy to take questions from staff or students who are interested in finding out more. So please do take that opportunity up. That's all for this evening. It's been really interesting, and thank you so much for those people who have tuned in. However you've taken part, and thank you particularly for those people who've submitted questions. And it's good night from the Twilight lecture for this evening.